really glad we got to talk about really a spectrum of studies that cover the range of science and healthcare delivery.
When saving lives is what you do, your standards are anything but standard. In fact, you set them higher than most to deliver results that patients can depend on. You refuse to compromise. We couldn't agree more. We are Edwards Life Sciences, and like you, we believe that good is never good enough. Rising to the challenge of today's TAVR patients isn't just a mission, it's a commitment. And because you set a higher standard, we set our sights on meeting you there. Welcome to the higher standard, your standard. Learn more at edwardstavr.com.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD from the Cleveland Clinic.
Hello, everyone. Welcome to another episode of Parallax. We're closing in on 2021. And to everyone who's celebrating the upcoming holiday season, season's greetings from the entire team at Parallax and Radcliffe Group Limited. So moving forward, my guest on today's show is a special person. He is the vice chair of scientific sessions at the American Heart Association annual scientific sessions. Is a professor of medicine at University of Texas Southwestern Medical Center and also the director of Preventive Cardiology, Dr. Amit Khera. So Dr. Khera, welcome on the show, and thank you so much for doing this for us at such a short notice. It's a pleasure to have you amongst our listenership at Parallax.
Well, thank you so much, Dr. Kalra, for having me today. I'm really excited to share a little bit about sessions and some of the big trials and to chat with you and your audience about this.
Absolutely. So, without much further ado, let's dive in. So the scientific sessions at American Heart Association annual scientific sessions was another virtual event. I'm positive both you and I are hoping that come 2022 we actually get to meet each other in person, because that's one of the biggest draws and charms of the meeting is to meet colleagues and friends from around the globe, essentially, in person and get to know a little bit more about their lives. But again, despite all the challenges that everyone has faced, I think it was an incredibly well organized scientific sessions virtually, and some incredible science was presented. And the reason why I wanted to do this episode with you was to sort of garner your insights as to what you think were 3 studies which were presented at these scientific sessions, which you thought are either practice informing or practice changing, for the entire gamut and spectrum of patients that you see, both in clinic as well as in the hospital.
Well, thanks for that sort of, orientation to sessions. I couldn't agree with you more. We all certainly wish and hope for an in-person event. Obviously, that means that we're all in a safer place societally. So we are really focused on an in-person meeting next year. But, we're all learning. We do take some positives away. We're learning about the virtual platform, and we were able to reach people all over the world and bring in discussants from all over the world in ways that we haven't been before. So we're hopeful to take these new learnings with us. And, as you're pointing out, some of the core findings of the meetings, the most excitement is around these late breakers. Of course, there's tons of other content, but I'm glad we're focusing on the late breakers. And I will talk about 3 today. And the first one I wanted to talk about was a study called Avatar. And, we had 7 late breaking sessions. This was the first trial presented in the first session. And the reason we chose this was there was something very special in our trials this year. We had at least 4 large randomized cardiothoracic surgery trials. And, those are very hard to do, and you don't see many of them. And these were really all well done, and we think practice changing. So I'm going to talk a little bit about Avatar. As you know well, this was a randomized trial with a very important clinical question. For those that are symptomatic, fairly straightforward what to do. even we have data now in those with very severe aortic stenosis, peak velocity is greater than 5 meters per second. But these folks were asking about asymptomatic, maybe a little less severe, but yet severe aortic stenosis, and whether we should be doing prophylactic aortic valve replacement. I think that's a critically important clinical question.
Yes, I couldn't agree with you more. Both you and I see these patients, I would say, not infrequently in our practices. And let's begin by, asking you a question as to what is your current, or what has been, prior to the findings of the AVATAR trial, which was presented at the American Heart Association, what has been your clinical practice in managing these patients in the office?
Yeah, right. And things are changing, obviously. Those with very severe aortic stenosis, peak velocity is greater than 5 meters per second. We have had, guidelines and a recent trial in the New England Journal of Medicine suggesting that, prophylactic interventions in those individuals can be beneficial. But this group with a little less severe aortic stenosis, velocity is greater than 4 meters per second, meeting the severe criteria, but truly without symptoms. So in this study, they actually had them do an exercise treadmill test to confirm that they really were asymptomatic individuals. And those individuals, my practice is watchful, close waiting, seeing them frequently, at least every 6 months, being very intentional about interrogating for symptoms. Many of us obviously will do a stress testing to elicit whether or not there actually are some hemodynamic complications or exercise intolerance. So, really watching them closely, doing some investigations. But, up till now, really we weren't doing prophylactic intervention. So that's where this is a very thought-provoking study in changing the way we practice.
Yes. So why don't I have you talk more about the study? So, essentially a physician-initiated trial, about 160 patients. And like you said, valve area less than 1, mean gradient of 40 or more, and a peak velocity of over 4 meters per second. So, meets all the traditional criteria for diagnosing severe aortic stenosis. Like you said, it's not very severe. Mean age was about 67, STS with score, which is Society of Thoracic Surgeons predicted risk of mortality score, is one of the scores we use in outpatient clinics to document what is the risk for that individual patient going into that procedure. It was about less than 8%. So again, patients that we see in our practices not uncommonly. What were the findings, Dr. Khera, for this?
Sure. And just to add to that, of course, we want to round out, this was 9 centers in 7 EU countries, but largely from one center. So we'll sort of talk about the pros and cons of the study. But as you were just discussing, had to have severe aortic stenosis, but excluded those with symptoms on a stress test, those with very severe aortic stenosis greater than 5.5 meters per second. And then they were randomized, 157 individuals, to conservative treatment, essentially what we generally do, or to early surgery. Now, again, that's not what we normally do. And I having spoken to investigators myself, I give them a lot of credit because this trial started several years ago. It takes a while to accrue patients in such a trial. So their forethought was quite good at that time. Ultimately, what they were looking at was average cardiovascular outcomes. The primary outcome was all-cause death and MACE, which included acute MI, stroke, and unplanned hospitalization. So that was the primary endpoint. Now, it was not a very large trial, as mentioned, 157 or so individuals. But what they found was a marked reduction in the primary endpoint. The event rates, looking at this, the hazard ratio was 0.46, so 50% reduction in events in patients in the early surgery group. Now, looking at it numerically, you can imagine there were 26 and 13 events, so not a large number. So there's one limitation. These are always challenges in the surgical studies. So any individual endpoint will be a little harder to interpret, but that was consistent. All-cause death was 16 in the conservative versus 9 in the early surgery, and heart failure, 7 in the conservative and 1 in the early surgery. The operative mortality, as we know, for aortic stenosis in general, especially those that aren't that ill, is quite low, only 1.4% operative mortality. So in total, I think what this tells us is reminds us that surgery is generally safe in those without a lot of comorbidity undergoing aortic valve replacement. The second thing is, this watchful waiting, a lot of bad things happen during that time. Here, we at least saw a trend towards all-cause mortality, but, in even heart failure hospitalizations or treatment for heart failure. So it really does make us think about this, about how this will impact guidelines, whether one study, reasonable size for a surgical study, but not terribly large, to what extent that will impact guidelines. But I do think it will inform guidelines. And one thing which you and I can certainly talk about, which has come up, is, to what extent does this translate to TAVR? This was a SAVR surgical group, so early surgery using SAVR, not with TAVR. So a lot of questions have come up about that, about how this translates.
Yes, and I'm glad you brought up TAVR as well, because that sort of becomes not only a physician choice but also a patient choice because of the invasive nature of surgery. I mean, don't get me wrong, TAVR is also an invasive procedure, but in comparison with surgical aortic valve replacement, it's a much less invasive procedure compared with open heart surgery, and so it's a request which is often driven by patients and their families. And, I think whether or not we can extrapolate these results to transcatheter aortic valve replacement, I do know we have an early TAVR trial that's currently enrolling patients. I think that'll answer that question for us. So knowing what we know now, for example, the Avatar trial, as you mentioned, was a difficult enrollment. I'm not sure how quickly will early TAVR enroll. I think it may be easier to enroll in a TAVR trial compared with an open heart surgery trial. But again, that's my own assumption and bias, obviously. Do you think you can extrapolate these findings to patients who you see in clinic who are requesting that they have a TAVR compared with a SAVR?
Yeah, I think you said it right. The short answer is I'm not sure. I concur with you. As you said, TAVR is often patient-driven. There's a lot of patient enthusiasm for lesser invasive interventions. As we both know, we still don't. That may be the easier way out in some ways, but those things always have to be tested because durability, risks, appropriate patient selection. As far as we have seen, as you know well, also, in the TAVR space, first starting at the very highest risk, then intermediate and even lower risk, it does seem to be a reasonable alternative to SAVR. I do think the early TAVR trial will answer the question or help answer the question. And to your point, I do think it would be easier to enroll surgical trials. One of the things we had a lot of discussion from all our surgeons and had some great commentary, just reminding us how hard these studies are because there's less equipoise going into surgical studies, both from the investigator, maybe even the surgeons and the patients. So those are harder to enroll. So I do think, as you pointed out, early TAVR could be easier to enroll. My take home on this in the end is we're not sure. So this is, and I don't know that we're ready yet to start operating on patients with this indication. But what it does make me do is perhaps lower my bar a little bit. We sort of wait until there's either a very severe velocity or very severe indicators on the valve or symptoms. And so we sometimes keep that bar a little higher than it needs to be. And that can be a bit subjective. So it certainly makes me realize that that bar may be a little bit higher than it needs to be. But to your point, I think we do wait for additional study in this space. And I think early TAVR will be very helpful.
Excellent. So anything else you want to touch base with regard to the findings from the Avatar trial, or you think we should move on to the next study?
I think we've covered it pretty well. I think we can move on to the next study, but I do hope that both at the American Heart Association meeting and others, we continue to see high quality surgical studies. There's a cardiovascular surgical trials network, and we heard about some trials from them as well. And I think these are so important. As Avatar, you and I have discussed for a bit of time now, is really can be practice changing. So we definitely need more studies in this space and hope we continue to see.
Yes, that's an important message. I think, again, anytime you want to advance the field and push the envelope, there's going to be difficulty in enrolling patients. because it's difficult to convince the referring physician or the referring cardiologist that this is the right thing to do for the patient, that there's equipoise and we need to accrue more data. But I do think it's a service to both, the referring physicians as well as patients, if we can, garner more data into some of these questions, which continue to, they're vexing questions to answer, and they're not as straightforward and easy. So I couldn't agree with you more that we do need more randomized clinical trials in the surgical space. So just to sort of, reiterate and facilitate the comment you made there. So moving on, the next study from early intervention to treat a degenerative condition to early intervention in treating a chronic disease condition, which is one of the most important and potent modifiable risk factors for cardiovascular diseases, and that is benign essential hypertension or primary hypertension. And this is a study from across the globe, which was, I think, pretty neatly performed and conducted by, I would say, healthcare providers, in China. But I'm going to have you talk more about it.
Yeah, thanks for that setup again. And I chose this on purpose. You say, why did I choose these three? We start from one extreme, which is, advanced surgical techniques and the surgical trial, to something quite different, but incredibly impactful. So I am a preventive cardiologist. And again, to the AHA mission, is population health. Hypertension is the leading preventable cause of cardiovascular death in the world. So, hypertension is a scourge, and whether we're in low and middle income countries or high income countries, we are not doing very well in its management. And if we have time, we certainly can talk about some other hypertension work that came out at AHA, but this is a really interesting study. And here it's about innovation. Everyone knows high blood pressure is bad and needs to be addressed and treated, but how do we accomplish it? What are strategies? Now we have to go beyond just documenting the problem, but what are some creative and innovative strategies, and ones that scale on broad levels, not on just a one-off patient level? So here, this was a study out of China. Just to remind you, high blood pressure, first given the magnitude of the population size, but in China, about 28% of the population, or 292 million Chinese adults, have hypertension, and that's defined at 140. It's even higher at 130. So treatment, there's a large problem, a huge number of people, and that's beyond the adult population of the U.S. in those numbers, just in the hypertensive folks in China. And then treatment rates are quite poor. So there certainly is a need for innovation. Here, what they did was they invoked a village doctor. So these are sort of quasi-health professionals. They're not formally trained physicians, but they have some health role. And they sort of anointed them to help in blood pressure management. And in a large randomized trial in different in villages in China, I'll tell you more in just a minute. But so really the part what's amazing here is, again, not using traditional healthcare workers and then using these sort of local village doctors to administer the hypertension treatment in a large group of individuals to see how that would impact blood pressure care.
No, it's again, it's a neat concept. I think it resonates, or I would say is very similar to the concept of a social healthcare worker in India. I've had my medical school training and residency training initially in the early 2000s in India, and I remember as a fourth year medical student working with preventive and social medicine and going to these primary health centers or rural health centers where we would work with social healthcare workers who would then deliver the basic minimum primary care that's required to keep the village or that community healthy. So I think, again, a concept which I think is relevant for several countries. And I wouldn't call China as a lower middle income country, but a concept that is relevant in populous countries with low and middle income economies. And also, I think is an extremely important concept to talk about, for our listenership, because as cardiovascular healthcare providers, I should say, I think the vast majority of burden or the scourge of disease that we treat and care for actually is in the developing world. So it's extremely crucial as an important public health message and a public health intervention. But I'm going to have you talk about the intervention in depth or in detail for our listeners.
Yeah, well, you certainly have great perspective on that, as you pointed out. And so, as you know well, we just need different strategies in different areas, as you have seen. And, in this study, what they did, they took 326 villages from China. They randomized the village, so that was a unit of randomization, 163 in each arm, to this village doctor-led intervention where, this village doctor, the para-health professional, did have contact. They would follow sort of a usual algorithm, and then they had the ability to access a standard physician as sort of backup and support for more challenging cases. So in these villages, it ended up being quite a large number of individuals. There were 33,000 people that were randomized in this trial. They were a bit older, mean age 63. Again, they all had to have hypertension as an inclusion criteria. So they had to have systolic above 140 or diastolic above 90, or treated above 130 over 80. So sort of our more traditional hypertension levels for enrollment. So here's the thing is when they sort of initiated this algorithm with these paraprofessionals, the reason this was an amazing study was, to me, the magnitude of blood pressure improvement. So their primary outcome was the proportion of individuals that were getting less than 130 over 80 at 18 months. And the difference was 57% achieved this in intervention villages versus about 20%. That is a 37% absolute difference. That is astronomical in cardiology. Just as an aside, there's this great algorithm out of Kaiser where they, implemented, and it took over several years, improved blood pressure control from like 60 to almost 80%. This is even a much larger magnitude in a much shorter amount of time, in a very innovative way. So to see a 37% difference in blood pressure control is just outstanding. The other part was the blood pressure systolic difference was 26 millimeters of mercury different in the intervention, and it was 12 millimeters of mercury different in the usual care. So 14 millimeters of mercury difference. That is a huge number. From a population level, even 2 or 3 millimeters of mercury is meaningful for changing cardiovascular events and cardiovascular death. So that is really astronomical, a really exciting finding. Of course, this is, N of one in terms of trials, but, we when we looked at this study and we were trying to choose the best studies with our committee, the innovation here, the population potential impact of a demonstration project of a novel way to address hypertension in a unique setting, and most importantly, the magnitude of change in blood pressure was quite impressive. So we really were excited about this study. Again, to your point, you've seen different methods in India, as you mentioned, of using different healthcare type providers. But this is really exciting. And, in a minute, we can probably chat about this, but there were other sort of, on the other end of the spectrum, high tech, high touch innovations in blood pressure. This is the other end of the spectrum that really could be transportable to many places in the world.
Yeah, I mean, I think, when you were discussing the findings of the study, one of the numbers that you mentioned that actually really was astounding was an absolute risk reduction of 37%. What kind of intervention in terms of drug or device do we see nowadays that has that kind of absolute risk reduction? And we harp about it and we prescribe it and we sort of advertise it to our patients. I mean, obviously in the right spirit, but here you have an innovation in healthcare delivery with the existing armamentarium of therapies that you already know. I think it was a stepped up care approach based on how you should manage blood pressure based on the US guidelines actually. Here you see a 37% absolute risk reduction in one of the most potent modifiable cardiovascular disease risk factors. I think there's something to be, said about that.
Yeah, I completely agree. And again, that magnitude, as you pointed out, is profound. And it wasn't a fancy drug or a fancy protocol, right? These were sort of standard protocols that have been applied. Again, I think it started from the Kaiser model with commonly used drugs, step therapy with thiazide diuretics and other drugs in these algorithms. So it wasn't the drugs that were the innovation, and it wasn't anything complex. It was the delivery and how they used it and how they applied it. So I think hopefully, again, they're not every place has what we call a village doctor equivalent, but there could be something like that in different places. I personally think there probably would have to be some, local or semi-local or cultural aspects taken into account in different places around the world. But the concept of using paraprofessionals that are trusted individuals in local settings where it may be harder to access care and to work in a much, to use simplistic tools for population impact. It's really almost the opposite spectrum of what we do in the West in the United States and what an impact they had.
Yeah, no, I couldn't agree with you more. I think the one study which, just to sort of have not an allegory, but a comparator in the U.S., because, even in the U.S. we have, populations that are underserved and challenging, particularly, I know the American Heart Association has been at the forefront of reducing structural racism for, our patients as well as care providers. But the one study which comes close to, I think, the uniqueness in which the healthcare was delivered for this particular patient population was the barbershop study, in black barbershops. Do you remember that one?
I sure do, actually. And interestingly, the original barbershop study was with the Dallas Heart Study. One of my colleagues who unfortunately passed away, Ron Victor, who was the architect of the Dallas Heart Study, that was the genesis of it. And then he replicated it in Los Angeles using pharmacists and other individuals. But to your point, it was exactly what you said, where, he started with saying, let's see who are, first what he did was looked at what were some of the barriers, because we know that in African Americans, hypertension hypertension treatment rates are far worse than what we see in white populations and other populations, and particularly among African American men. So I remember Dr. Victor first went and sort of did a studies. What was it? What were some of the barriers? What were some of the beliefs? And then, where might you access Black men in a different way, and learning about sort of culturally the centerpiece of the barbershop and how that played a role in these individuals' lives. And then designing intervention, first understanding the patient, if you will, or the population, understanding their needs and understanding their local environment, and then designing the intervention around it. In Dallas, he learned a lot. It wasn't quite as impactful as what he did in Los Angeles. But when they did it again in Los Angeles and then kind of went beyond the structure of it, but then other components, the pharmacist component, other innovations, really, as you said, had a very impactful blood pressure lowering. And now this has been proven. I know we published this in Circulation. They've been cost-effective. This study showing it being cost-effective. So to your point, an analogy, if you will, in the U.S. was the barbershop study. I'll mention one other thing at Sessions. I keep alluding to this. There was a big study out of the Brigham and Mass General, which was a follow-up to last year. This big data approach where basically they had an algorithm in their EHR, and then they also had this pharmacist-led intervention where it was pharmacists and also navigators. So not even officially sort of medically licensed individuals, that where they use this EHR intervention to identify people with high blood pressure and high cholesterol. Then by a series of sort of some phone calls, but largely through a navigator and some texting, they reached out to them, implemented blood pressure and cholesterol management, and in a sizable proportion, several thousand, were able to get them to goal, both in blood pressure and cholesterol. And I mention that again because, again, another innovative strategy, this way in a healthcare system using an EHR and navigator, so very different than village doctor-led in China, but nevertheless an impactful way to improve blood pressure and cholesterol. And I mention that just so that we look at different approaches that can work in different settings, but all with the same goal.
Absolutely. And, that actually, the fact that you mentioned cholesterol and an EHR intervention, well, it's not an EHR intervention, but we are going to talk about a cholesterol intervention moving forward to our third study for the discussion for today's show. And that is, I believe, an area that probably excites you quite a bit as a I think it should excite all of us as cardiologists, but, specifically for you as a preventive cardiologist is an area of active interest in clinical investigation and your focus in clinical practice, and that is a cholesterol lowering therapy for patients who may be intolerant to statin therapy or, in addition to statin therapy, but I'll have you talk more about it. It's still in its nascent form in terms of how are we going to talk about the drug, but I believe it was MK0616. Did I get that right?
You got it right. Yeah, that's a mouthful to say that, but that tells you where we are. It's a phase 2 study. So now here's again the third opposite end of the spectrum, a small drug trial, and on purpose I sort of chose this one because it's really thought provoking, and we'll talk about MK0616, but also what this means to the field in terms of lipid management. So here, this was a phase 2 study of an oral PCSK9 inhibitor. So well known to you and likely your audience as well. We had what was prematurely thought the death of the lipid field after statins. There was sort of a long pause. Ezetimibe came, but then there was not much for a long time. But we've really seen the rebirth of the lipid management field that aligned with for many reasons. Part of it a larger focus on familial hypercholesterolemia and recalcitrant high cholesterol. So fortunately, we do have PCSK9 inhibitors. These are largely monoclonal antibodies. They work well. They're potent. I prescribe them frequently because I have an FH program and see a lot of patients with premature vascular disease and dyslipidemia. So those work. We have 2 randomized trials with outcomes showing improvement in cardiovascular outcomes. However, those drugs are still reasonably expensive. Here in the U.S., they're about $5,400 a year. And there are injections. Now, my personal opinion, I when they first came out, there was a lot of reluctance in the cardiovascular field because we're just not used to injectables. In the rheumatologic and other spaces, no big deal. But for whatever reason, there's just some anxiety around that. In my experience, at least people have tolerated it very well. And once they get over the mental hurdle of a injectable, they do quite well. But some people still don't. That's still not for them. They still don't want to take an injection. There are some occasional side effects or intolerances, and cost is still an issue. So this is where this comes into play, which is an oral PCSK9 inhibitor. So to tell you a bit about it, and I learned a lot about it in the presentation itself, one has to get back to why is this such a challenge? Why don't we have this already? And part of it has to do with, the reason we're with monoclonal antibodies is these prior PCSK9 affecting mechanism drugs, they weren't getting absorbed and reaching the target. So they had a targeting problem. There's a problem with absorption of some of these peptide and other small molecules that people have tried to develop. So they came up with a workaround. They have this cyclic peptide platform, which we all learned about, where they have some absorption of a compound that can target PCSK9. And equally as much, one nuance here, which I'm sure will come up in our discussion, it does have to be bound to something that helps with what they call a permeation enhancer, so that it can be absorbed. And that did come up in the study where there can be some problems with absorption if it's not timed right with a meal. So that's part of it is timing and binding. So they had to come up with a neat, innovative platform to deliver this small molecule to bind with affinity against PCSK9. So this was a phase 2 study. They first started with one small study predominantly in men, just looking at different doses and the concentration. I'll skip over that, but talk more about the part of the study with 40 individuals where it was a randomized placebo-controlled double-blind study, multiple doses, looking at once daily dosing for 14 days, a short study with this MK0616, different doses, 180 versus 360 milligrams, and also looking at food and the binder. And so I'll cut to the chase, but what they found was a pretty marked reduction in their highest dose 360 with the appropriate binder. They saw about a 60% reduction in LDL compared to baseline in this with use of this medicine, daily dosing. So we're getting efficacy comparable to what we're getting with the injectable sub-Q PCSK9 inhibitors and monoclonal antibodies in an oral version. So that again, phase 2, not fully developed, but the concept of now having an oral version, and what we can talk about in a bit, we have potentially an evolving oral version. We have a monoclonal antibody sub-Q every other week. And now, at least in Europe already, and perhaps in the US soon, another compound, a silencing RNA, which can be given every 6 months. So boy, from not having many options at all to perhaps in the coming years having numerous options in this targeting pathway.
Yeah. So, well, thanks for taking us through the study. My first question to you is, what percentage of your patients? I mean, and I'm specifically asking this to you because you would probably see a lot more of these patients compared with me. I do prescribe PCSK9 inhibitors, but I think in practices with focus on preventive cardiology and specifically patients who are statin intolerant, which colleagues like us probably refer to you. What is the percentage of such patients that you see that you prescribe the injectable PCSK9 for?
Yeah, it's a great question. Of course, I have as you pointed out, I have an unusual practice. I see all what I like to call the numerators of all the patients that have the issues or problems or very high lipids that get referred to me. A fair proportion of them. So as you pointed out, the individuals where PCSK9 inhibitors currently are FDA approved here are those with familial hypercholesterolemia with residually elevated cholesterol despite maximal statin therapy, or those with atherosclerotic cardiovascular disease. And our guidelines would say if they're very high risk and their LDL is not less than 70 after being on statin and ezetimibe. People have modeled that. It ends up being, perhaps as much as 20% or so of the ASCVD population. But I think part of it is where we are today and then where we could be in the future. And I say that because our guidelines that came out, the U.S. cholesterol guidelines in 2018, we had this magic number of 70, and the algorithm went for ezetimibe first before adding PCSK9 medications. Part of that was, at that time, only one of the two PCSK9 trials had been published. The other was, I think, came out right around that was presented at the same meeting as the 2018 guidelines. So there was a data lag. The cost was more, it was $14,000 a year, and there was not much experience with injectables. As you probably know, the European guidelines are more aggressive, and they recommend in our higher risk patients LDL goals of under 55 and perhaps under 40. And there's been a lot more data about those lower numbers and no floor as to reduction of risk. There's been a few more papers recently about other risk enhancers, and finally, even some more recent thought-provoking at the AHA. Again, we had a whole session on what's primary versus secondary prevention. For example, people with calcium scores of 1,000 have an actuarial risk of ASCVD events comparable to someone with stable CAD. So I think there's a broader pool of patients that could be potentially appropriate for more intensive lipid lowering. And so I think, and also our targets and goals may end up being more aggressive as we learn more. So I think there could be a much larger opportunity for all of these medications.
Yeah. So great comment. So my follow-up question to you is that have you used, or do you use, or do you even recommend or think that there may be a patient population which may derive a benefit from incremental prescription of PCSK9 on top of statin therapy?
Certainly. And I see several of those, particularly those with FH that have LDLs that are, maximal statin therapy and still have high LDLs. Some guidance would say less, above 100. Certainly those that I see with ASCVD with LDL above 70, and occasionally even targeting lower. So unquestionably, there are those patients. And I think, now it's whether as we get more options, if inclisiran is FDA approved, it's available in Europe. Do you use every 6 months? Do you use every 2 weeks? Do you use an oral option? So this is what we'll have to figure out as a field. And part of it, back to maybe our initial discussion about valves and TAVR, what's the patient preference? What's best for them? Cost, tolerability, and all those issues.
Excellent. So where do you see these? I guess my question to you should be, in what percentage of patients do you see, a preponderance of side effects to injectable PCSK9 for you to then give them the option of an oral PCSK9?
Yeah, I think that's a great question. So we always have to temper enthusiasm with reality, right? And so, the temperance here are twofold. First, this is a phase 2 study. We don't have more data. And so this is not a drug that's FDA approved, but, a good proof of concept, because before this, there was no, as far as I know, an oral PCSK9 version that had sort of looked promising like this. The other temperance, I'd say, is, we have outcomes data with the subcutaneous, the monoclonal antibodies. We have two randomized outcomes trials. One wouldn't know why that would be different, but you don't actually know that until you study that with an oral drug. So a couple of words of caution. And to your point about proportion, there's not a high proportion. It's pretty small, the proportion that can't tolerate a subcutaneous. It is a smaller proportion. If I ballpark based on my clinical experience, it's small, maybe 5%, 10% tops. There also is some other components. One is just aversion to shots. Again, not a high proportion, but in that 5 to 10%, that's probably bundled patients with a side effect, whether that's real or perceived, patients with a perceived intolerance or dislike for needles. And there may be some cost issues too. I would not know the pricing of what an oral drug would be relative to a subcutaneous, but again, at $5,400 a year and with some high copays to some patients, that's been a bit of a barrier. So these are all niche areas, but I'll come back to, individuals that may end up being a small proportion of individuals, but the ones where we're actually thinking about these are ones that are in high need. So those that, again, have FH or high risk secondary prevention, that have residually high LDL. So there are always going to be patients that have needs where having a broader toolkit is valuable to meet those needs.
Excellent. No, thanks a lot for today's discussion, Dr. Khera. It's been very enlightening for me, to learn all these nuances in, prevention and statin therapy and PCSK9 inhibitor therapy. Also, we talked about innovative healthcare delivery, interventions and, certainly early surgery for patients with asymptomatic aortic valve stenosis. Do you have any closing remarks for our audience, our listenership?
Well, I do. First and foremost, thank you again so much for inviting me. It's been really fun, and I'm really glad we got to talk about really a spectrum of studies that cover the range of science and healthcare delivery. To back to where you started, I hope you and I get to do this maybe again next year after we see each other in person in Chicago for AHA 2022. I'm optimistic that we will do that, and hopefully we'll have a lot more to discuss. But again, thank you so much for inviting me today.
Well, thanks again for your time and for your expertise, and really enjoyed having you on the show. And, hopefully, we can do this in person next year in Chicago. But until then, if I don't get to speak to you again, wish you and everyone at UT Southwestern. I know I have a lot of friends at UT Southwestern, from you and Ambrish and Dharam and Dr. Hill, to now also Preeti, who's at the clinic and who's now with you. I wish you all a very happy holidays and season's greetings, and we'll get to have a conversation with you soon.
Thank you. You as well.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.